yeah, this is a first for me doing, I think this presentation by Zoom. I've given this presentation, well, versions of this presentation, which I kind of always tailored a little bit depending on the audience. I've given a number of times, and then I adapted a little bit. So hopefully it helps. It's unfortunate we don't have any of during the course we would get to do more of like the live demos, and which is always more exciting to be able to do things hands-on. But hopefully these are just some of the principles that you guys can take with you and apply to your own practice. I'm really big on, this is something that was ingrained to me probably towards the end of my residency, and especially in my fellowship, and is really big among the minimally invasive community, is ingraining these principles of electrosurgical energy, because there is one thing that's probably very poorly understood among all surgeons, and part of the pervasive,ness is that the lack of understanding about these principles just gets passed on through. I said even among senior surgeons who are experienced, they don't. I think very few people actually understand this, and it's really kind of going back to why you learn physics and all this stuff as a prereq to get into med school, to understand a bit of these principles. But the real value is that if you understand how these instruments work, it'll make you a better surgeon, it'll make you a safer surgeon, because ultimately you as a surgeon are responsible for the tools that you use, which it includes an instrument that we use almost every single day we're in the operating room, which is the electrosurgical generator and all the instruments that are associated with it. Many people really fully understand it. So that's part of putting this together to talk, and it takes a while. A lot of people, even myself, I took multiple courses on this, and I think I had to hear even my own talk. I kind of learn as I go through and review the material. But I think it's something that you just need to keep hearing over and over again to reinforce it. And even the working title, Nicole, I'm going to pick on you a little bit, but which says all you should know but don't about electrocautery. And there's a lot of terms which are poorly used, so I would get shot if I had a presentation with that title. So we'll learn why electrocautery, why that's not the right terminology that we should be using if we're going to understand it correctly. So I'm going to share my screen, and hopefully it works. Can everyone see this now?
Yep, looks good.
The slideshow? Okay. Start. Okay. So now I lost everyone else. Let me see if I can get that back. Okay, if someone has any questions, just speak up. Because I lost my view of what shows where.
You might want to switch which screen you're sharing, I think, because we can see the presenter notes.
Yeah, the presenter view, right? Yeah, let me try it again here.
And then you might be able to see us again.
Okay, here, let me start this. Let me try it again. Share screen. Does that work?
Yeah, that's better.
Okay, here we go. Awesome. Okay. And then now, as long as the rest of it, trying to see. Oh, okay, there we go. Okay, so the objectives of this talk, I'm going to focus for the purposes of OSS program, is the most of what we use at open surgery, which is monopolar energy, and those buttons of cut and coag. And the goal is to understand so you know what those mean. I'll mention a little bit about bipolar energy, but I'm not going to talk too much about that. That'll apply more to the laparoscopic stuff. And if we have time, we can answer some questions as it relates to that. What I really want you to understand is how these energy settings relate to tissue effects. Because if you understand how the machine works, you can understand then how that relates to the effects that it has on the tissue. And ultimately, the goal is to make you a safer surgeon. So this is cautery. And this is what we first started with, which is if you had a little bleeder, you kind of just heated up something, and like you see in the movies, just give it a little bit of direct heat energy and you cauterize it. Electricity. And then this is electrocautery. So electrocautery is using a direct current, an electrical current, to heat up a electrical element, and then by creating that resistance, you generate heat. An example of this would be an iron, for example. You have the iron is creating direct heat because it's getting hot and is using electricity to power it. So that's electrocautery. That's not what we're doing. The instruments that we're using aren't generating a direct heat. What we're doing is electrosurgery. And that's the term that I want to impart on you. So cautery is a direct use of heat. Electrocautery is the process of destroying tissue with an object that is heated with electricity. And electrosurgery is using a current that actually passes through the patient to cut or coagulate tissue. Versus electrocautery is where you don't have any current that's actually flowing through the patient. For example, an iron, if you think about it that way. So going back to some of the fundamentals, which are important to understand electrosurgery. So think electrosurgery or electricity is basically electrons. So think about we're moving electrons from one place to another. Basic principles of electricity is that electricity always seeks the ground and always seeks the path of least resistance. We have some words that you probably may not have seen for a while. So we have current, which is the flow of electrons that occur over a period of time, and we measure this in amps. We have a circuit, which is the pathway that the electricity or electrons follow. Along that way, we have objects that resist the flow of the current, and which is measured by the impedance. And in a person, that's the tissue. And different tissues have different levels of impedance or resistance, which can affect your flow of electrons. We have then voltage, which is the force that pushes the current through the resistance. And power is what's known as the work over time, and that's measured in watts. Now, a question to you, and I'm going to get some audience answers in a second, which is when you put a setting on your machine, when you set that setting to 30-30, 40-40, whatever it is that you're using, what is that number? What is the unit of that number? And you guys can unmute and answer if anyone knows the answer or wants to take a guess at it.
My guess is it's amps. It's the current flow.
Okay, we have one vote for amps. Anyone else? We only have 10 people on here, so I can just start picking people for voting. Okay, we have amps, we have volts, and we have watts. So if I were to...
I'm just going to go for volts just because I have no idea.
Okay. Can we get a show of hands for volts? Okay, 1, 2. And a show of hands for amps. Okay, anything else? Okay, good. You guys are going to learn something. So everyone's wrong. So the answer is watts. Okay, so when you set the number on here, so we go back. So voltage is the force, power is the watt. So what you're setting is the power setting, is you're setting the amount of watts that's going through the electrosurgical units and through the patients. So that is important to know when we understand the later principles later on. So, and it's important in your dictate, and the way you remember, just start putting in your dictation. You know, we use the energy setting of 30 watts. So the way we understand our circuit is if you think of the generator as a pump, as a water pump, and think of the current as, or think of the electrons as water that's flowing through this pump. So water is stored in the ground, or it's stored in the, the electrical socket essentially, and then which goes to the generator. And that generator is generating a force that is pumping those electrons through the circuit to generate a current that flows. So the current is measured in amps. So the generator sets a certain voltage, which is how much force it takes to pump those electrons out of the generator and into the patient. And along the way, it meets its resistance. Now, when you set the power of 30 watts or 40 watts, what you're saying is you're saying that I want to do a certain amount of work over time. So let's say if we use a water analogy, let's say if we're saying 100 liters. So we're not saying I want you to do 100 liters. I want to say you want to do 100 liters a minute. So the generator, so let's say if I sent it at 30, that says, so let's say I use 30. If you set it at 30, it says, hey, I want to do 30 liters a minute of water that's going through this circuit. Now, if you change something like the resistance, if you increase the resistance, you're going to make it harder for that water to flow. But you still told your pump that, hey, I want to work at, I want 30 liters a minute still coming out of this pump. Well, this pump is going to have to work harder to get those 30 liters a minute through because you've told it that that's what I want to get. So the resistance affects the amount of voltage that's generated by the machine, or the amount of force that's generated by the machine. And we'll talk about how that comes into play a bit later. Does that make sense a little bit in terms of, and stop me if you guys have questions, because I want to make sure you're following as we go through this. Now, in our circuit, we don't just have water pump that's pumping up to the ground and flowing out and into nowhere. We actually want to capture that water back. We want to capture those electrons back. And so we have these, which are not grounding pads. Grounding pads is the wrong term. These are called return electrodes. So grounding pad means that the electricity or the current is being pumped out into the patient and then to the ground and then out of the way. That's not what our pump is doing. Our pump is saying, well, I don't want to waste all this water, or I don't want to waste all this electricity. I want to make sure that's not leaking anywhere. I actually want to take into account of how much electrosurgical energy is going through the circuit. So I want to have my return electrode, which is capturing the electrons, and in our water analogy, having something here that's capturing the water that's coming through and creating a circuit. So it's kind of going back and forth. So you don't want much of it leaking out. So it's a return electrode is the proper term. So this is our circuit. So we have our electrosurgical generator, which goes to our output electrode. So, and this instrument can be anything. So at laparoscopy, it's, you have your hook. It's this at other surgeries. If you do hysteroscopy, you have a roller ball. So it can be any multiple different instruments. Then you have the energy goes through the patient because the patient is part of our circuit, and then it's attached to a Turner electrode, and it goes back to our electrosurgical generator. So this is our circuit. This is our pump that's working through. Now, a question is that our generator, so you can generate 30 watts of energy, and you can set up to 300 watts of energy, which is a huge amount of power. But our socket, if you guys look at the number, is 120 volts. So why don't patients get electrocuted when we're using this much electrosurgical energy that's going through them? Because the patient is part of the circuit. Why don't they get electrocuted? Tom, have an answer?
I'm not meant to be answering, but small amps, small amperage.
Small amperage? You can. No, that's not the answer. So
I think they are getting electrocuted.
What's that?
I think they are getting electrocuted.
No, they're not getting electrocuted. It's a good theory, but yeah, no, they're because electrocution has to do with muscular nervous stimulation. So for the most part, you aren't stimulating their muscles and nerves. Well,
High resistance?
resistance. No, it's something I haven't talked about. Slightly trick question, but has to do with the frequency. So electrosurgical energy generates the energy in the radio frequency range. So just like we have Wi-Fi and all these signals going through the air, we're not getting electrocuted by all this energy and stuff like that that's going through the air, because it has to do at a frequency that's not causing muscle and nervous stimulation. So it's the same thing with electrosurgical energy. It's operating at a lower frequency range than that which causes muscle and nerve stimulation. Usually any twitch or anything that you see is related to direct stimulation of a nerve, if it were to happen. But the patient itself, the energy, the electricity that's flowing through the patient is in a frequency, just like you have Wi-Fi and all those things going through your body all the time. It's not enough that's causing stimulation, and therefore people don't get electrocuted. But if you stick your finger in a socket, you will. So this is our monopolar circuit. So a monopolar circuit is we have our electrosurgical unit, you have our active electrode, so that's the term that we refer to. So the active electrode, which is the one that's active on the patient. Energy is flowing through the patient and coming back through our return electrode, and then coming back to our electrosurgical generator. Now, at open surgery, I think for a lot of what we do, in gynecology and obstetrics, we don't use much bipolar energy. But if you were to use bipolar energy, what bipolar energy does is that the reason why it's called bipolar is that you have the electrosurgical unit, gets to your active electrode, and your active electrode has two poles. It has a positive and a negative. So it goes from one side to the other side, comes back through the active electrode, and then comes back to your generator. So the patient is not involved in the circuit. So does anyone here do laparoscopy? No one here does. For the few people who've done laparoscopy or use bipolar energy. So the question is, do you need one of these return electrodes when you're using bipolar energy? How many people say yes? How many people say no? A few hands? Yeah. So the nurses will put it on, but you don't actually need it because the patient is not part of the circuit in this case. The return electrode is only if you're using monopolar energy where you have the patient as part of the circuit. If you're using bipolar energy, you don't need a return electrode because the return electrode is in the instrument itself. So it goes one way, comes back the other way. And it's not part of this talk, but if you get into some of the advanced energy sources, so there's things like the ligature biclamp or other similar instruments that we call the advanced energy sources, those are all forms of bipolar energy. So again, those are electrosurgical energy, but don't have a return electrode because the patient is not involved in the circuit. Now, a really important part, if you do use bipolar energy, this is actually a really important part, is as I said, energy always flows, electricity flows through the path of least resistance. So the path of least resistance, the thing that allows electrons to flow the easiest is metal. So sometimes you have a really fine little tiny bit of tissue. And if you don't have enough tissue that's separating these two ends of your instrument, if this end is touching, then what happens is energy is going to flow through the one end and go back to the other end and isn't going to affect the tissue. So sometimes if you're using a bipolar instrument and you find that it's not working, part of it is you just need to create a little bit of space so you don't have energy flowing from one side to the other side. So if anyone's ever come across that, again, usually at laparoscopy is where you notice it. So we have monopolar, we have bipolar. Again, most of what we use is monopolar. Now, what's the difference between cut and coag? Does anyone want to take a guess at it?
Is it the frequency?
A little bit, not exactly. When you say frequency, what do you mean by that?
Like if it's like, I think one is like, it's like consistently going and then the other one like stops and restarts.
Okay, right. So, and which one is which?
I think cut is the more constant and then coag is the one that stops and restarts.
All right, that's correct. So, of all of electrosurgery, this is the worst term that could have ever been created for it because cut is for cut and coag is for coag, and that's how people use it. They think, oh, for cutting, if I'm cutting tissue, I use cut, and if I'm coagulating tissue, then I want to use the coag. And that is actually what you'll hopefully realize is that's actually not the case. And the real problem started with the terminology, because the buttons even say that. They say cut, coag. And I think that whole thing has just created confusion all along the way. So the correct term with what it should be is what we call a modulated versus an unmodulated current. So a pure cut current, when you put cut, means that the energy is delivered all the time. So it's what we call a duty cycle. So it's a 100% duty cycle, meaning those electrons are constantly flowing throughout. And because it's constantly flowing throughout, again, what you're setting on your machine is wattage. So you're saying, I want to do the same amount of work over time. So you have two ways of doing that. You can either deliver a constant amount of energy over 100% of the time, or what happens in coagulation mode, which is what's called a modulated current, is you only deliver energy over 6% of the time. So it says it turns it on and then it turns it off. Now, where that comes in I usually had a slide here, but where that comes, if you think about our water pump analogy, what you're saying when you're doing the cut current is you're saying, well, I want you to pump 30 liters a minute. So the pump says, okay, I'm gonna pump 30 liters a minute. So that works out to what, half a liter a second to pump because it's on all the time. When you use the coag mode, you said, and you have it at 30 watts. it's work over time. So you say, I still want you to do 30 liters a minute, but you can only operate for 1 second of that 1 minute. And you have to give out all 30 liters over that 1 second that you're allowed to operate. So what does the pump have to do? Well, for that 1 second, it has to give this huge burst of energy. So it has to deliver those 30 liters all over 1 second, as opposed to the 5 seconds or half a liter a minute, over the 60 seconds. So the voltages, the amount of force that instrument has to generate is really high. And this graph is misleading because it actually looks like this when you compare the two. So in a similar setting, when you look at what they call the peak opening voltages, when the cutting current or the cutting mode is activated, you have low peak voltages. But when you use the coagulation mode, you have really high peak voltages. Okay? Does anyone know what waveform bipolar is? If I want to take a guess. So bipolar mode, if you use that, is same as the cutting mode. So it's the one that's on all the time. It's a constant mode. Now, this is, I think hopefully this works. There we go. So this is just showing you just a visual example of what this is. So this is the cut mode. And you'll see the coag here. Okay, so that energy is just, with the cut, it's the slow amount over time, and then that coagulation mode, the high voltage, that energy just surges through. Now what we see, now those are the modes. How does it, what concerns us is how it affects the tissue. And we'll get to this. So if you have a setting, the main thing that we get when you use a cut mode versus a coag mode is char. And this is why. So you think about why we're using electrosurgical energy. So when you have electrons and those electrons encounter resistance, then that generates heat, and heat is resulting in tissue damage over time. So if you heat up something slowly in the early phase, you get areas of where you get tissue damage, denaturation, and then eventually the collagen denaturalizes. If you heat it up even more, the tissue starts to dry out, and if you cook it really hot, it's going to char. And what this plays into, I want to give this analogy. This is my turkey analogy, okay? And this is going to play to where you're going to have to stop bleeding. So let's say you're having to cook a turkey, it's Thanksgiving, and you're like, oh crap, I completely forgot to put the turkey in the oven. It's like your guests are coming over and they got an hour. You're like, okay, that's fine, whatever. I'm just going to stick it in the oven. I'm going to crank it to 600 and it'll be done. What's going to happen to your turkey?
I'll have a burnt raw turkey.
Right? This is what's going to happen to your turkey. Okay? It's going to be burnt on the crisp on the outside, raw on the inside. That's not going to work, right? And so this is what happens with your coagulation mode. So when you try to, so think about coagulation. Now think about, instead of cooking a turkey, you're trying to stop a bleeding vessel. Well, what's going to happen with that bleeding vessel is you're going to cook that bleeding vessel, and you're going to be like, oh, it's so charred, it's totally got to be cooked. And then what happens is you take off your, let's say if you're doing it with a pair of pickups or whatever, and you leave and you're like, oh, it's still bleeding. Like, what's going on here? Well, it's because what's happened is that your char is at high resistance. So you've totally cooked this thing on the outside, but now you created an area of high resistance, so nothing can get through, and it's completely raw on the inside. So if anyone who's ever experienced this, where you take your active electrode and you use coag and you cook that thing and it's char all around and it's still bleeding and you can't figure out why, well, this is why. It's because you cooked it on the outside but not on the inside. So how do we cook a turkey? What's the proper way to cook a turkey? So it's cooked all the way through.
Low and slow.
Low and slow. Low and slow. So low energy over time. So what mode delivers low energy over time?
Cut mode.
Cut mode, right? So if you're trying to stop a bleeding vessel and you have your pair of pickups, or if you're picking it up with a snap, whatever you're doing, and then you're taking your active electrode and you're touching it to it, the best way to actually stop the bleeding is to use your cut mode and just slow energy over time, and then you'll see it kind of crackle and then it'll dry out. Now, it takes 2 seconds of extra patience to allow yourself to do that, but you'll find that that's not how you'll avoid bleeding. Now, as I said, this is something that people who understand electrical surgery will know, and someone who doesn't understand electrical surgery will say, oh, just use coag and just cook the whole thing and create a whole bunch of char. But this is an example of what's happening. So when you use this cut form, so cut, again, it's bad term, low voltage, right? 100% duty cycle. You're getting gradual desiccation, deep penetration into the tissue. So you can actually, if you have a deep vessel, you can actually desiccate it. Versus if you use this mode, what happens is it's nice and charred on the outside. You think it's nice and cooked, but the penetration below is not anything. And then what happens is below, if you have any vessels or anything, they still bleed. Now, sometimes this is a desired effect, and we'll talk about that. But other times, in most circumstances, it's not what you want. So if you can't remember turkey, there's also sausages because they're more juicy and bleedy. So and it's more like a vessel. So this is what happens, right? You cook it on the outside of your vessel, but nice and raw, bleeding in the middle. Whereas again, low energy over time. You may get a little bit of crispy char. That's okay, but overall, you've taken the time to cook it all the way through. So the goal of this is what we call tissue desiccation. So when you have something bleeding, you're trying to dry out that tissue to stop the bleeding. So you can use either mode, but they'll behave differently, especially depending on how big that vessel is. So if you have like a really big vessel and you really cook it on with coagulation mode, you're still going to get bleeding, versus low and slow over time will allow time to completely dry out that tissue. So just kind of illustrates what you'll see. So this is what's happening with coag mode. You're getting lots of char, lots of tissue desiccation, but if it was bleeding underneath, you still may get a lot of tissue damage, but not good depth of penetration. Now, okay, so before I move on, is there any questions between that, with that analogy and understandings, or like the low and slow? Everyone's good? Okay. So we have 3 effects when we look at electrosurgical energy. We have desiccation, vaporization, and fulguration. So desiccation is we use when you want to stop bleeding. Vaporization is what you want to do when you want to, essentially what people call the cut mode, when you want to cut through tissue, and instead of using a scalpel, you're using a little bit of electrosurgical energy because you don't want to have it to bleed as much. And what vaporization is doing, so as opposed to desiccation, where you're slowly heating up the water content within the cells, and the goal is which is to dry out those cells. With vaporization, what you're doing is you are rapidly heating those cells so that the water essentially vaporizes and bursts the cells open, and then it essentially vaporizes. And the way that happens is when you create a little bit of a spark. So when you use the cut mode and you create a little bit of a spark, what that does is it rapidly heats, so you just barely touch the tissue. And the idea is what that does is that, and we'll explain why that happens, but it rapidly heats up the cells, causes water to basically turn into gas, and then the cell bursts open. So this is what happens. This is what the goal of this. So you're vaporizing the cells. You're not drying them out. You're basically vaporizing the cells away so you can cut through that tissue. Okay, just show that again. Okay, so that's vaporization. It won't work if you use the coag mode because we'll see what happens there. So this is fulguration. So if you use a coagulation mode, now you can do it with a high energy setting, but what's happening with when you're doing with your fulguration is because it's a 6% duty cycle, what's happening instead of vaporizing the tissue, and if you stay on one spot, what it does is it gives these bursts that are on and off. So if you have a high energy burst that's on, what happens with high energy over a short amount of time creates char. So you have char on the top, which then has high resistance to flow, and then everything below stays completely raw and uncooked. So what fulguration does is you have this high amount of energy, which creates a lot of char on the top and helps stop the bleeding or anything that may be going on superficially. So that's what this is. Okay, so that's fulguration. So we have desiccation, vaporization, and fulguration. So what you have to decide is when you have a bleeding vessel, is that vessel bleeding, is it a superficial bleed, meaning mainly if it's more like a capillary bleed, then that's good for fulguration, and you use the coag mode. If you have something that's, let's say, a deeper vessel, something that you can actually, when you pick up and want to grab that vessel, then you're thinking, well, hey, this is something that I want to make sure I get down to the center. I mean, I want to make sure it's not raw, and so I want to use low energy over time. So I want to use the cut mode, and that's what will give you optimal desiccation in this circumstance. Now, that's not to say that you can't use coag mode to stop that bleeding. If you totally blast something with energy, if you take a flamethrower through it to your turkey, eventually you're going to cook the whole thing all the way through, but then you just have char and tissue destruction everywhere. And so that's the consequence. And from an electrosurgical point of view, what we know is that char is where bacteria like to grow. So when you create lots of tissue destruction, that's going to create more potential for rhinitis for infection. So that's the rationale behind minimizing your use of electrosurgery. You want to stop the bleeding, but you want to don't have all this like charred tissue everywhere and then closing it up. So this is our electrosurgery energy. So we have vaporization, so cut mode, which only works in monopolar, and constant duration, so it vaporizes the tissue. Fulguration creates sparks, which is the short duration and high voltage, and desiccation, which is energy that's passing through over time. And depending on what mode you use, you'll either get a deeper penetration or you'll get more of a superficial penetration. Vaporization, fulguration, desiccation. So a way to shift your thinking, if you can try to do this the next time in the OR, is don't think, do I want to cut or coagulate this tissue? Think, what do I want to do? Do I want to vaporize it, fulgurate it, or desiccate it? And if I want to do, what mode of my button do I want to use in order to achieve that tissue effect? Vaporization, fulguration, desiccation. Keep those three things in mind. Now, an important part of understanding vaporization and when we use electrosurgical energy is this concept of current density. So current density is basically how many flow-ons, how many electrons are flowing through any given point in your circuit. So if we go back to our water pump analogy, so we have our pump, electrosurgical generator, pumping out energy, it's flowing through our circuit, and in the end, we have our hose. So we have our hose, and we're trying to water our plants, or we're trying to stop, or in this case, pour electrons over our patient. Now, there's two ways to, let's say if you're watering your plants and you wanted to now all of a sudden spray that water fountain across the room. There's two ways to achieve that effect. One is you can really turn up the water from the hose. You can turn up the water pressure and generate more pressure to go further. But how else would you achieve that effect? Someone's making a motion. Nicole's making a motion.
Narrow the nozzle.
What's that?
You'll narrow the nozzle.
Narrow the nozzle. Exactly, right? You narrow the nozzle. So what you've affected here is your current density. So you still have the same amount of power that's being generated. So your faucet is still at the same setting. You haven't touched the amount of water that's coming out. You're still having 30 liters a minute of water coming out. Your hose is the same, so your resistance of the thing is the same of the tissue, but what you're changing is the current density. So you're saying I want all that water, that 30 liters a minute, now to come out of a really small little point. And so pressure is equivalent. So pressure is force, and force in electricity is voltage. So that's how much force is being generated. So when you narrow your current density, you have high voltages. And high voltages is what leads to more heat over time, or more heats, yeah, sorry. So where it really plays out is you can see that even a small change in diameter, you get these massive changes in the amount of energy that's going through your current density, right? Because it has to do with surface area. So you cut the diameter in half, and you've massively increased your current density. So that's what's happening when you vaporize something. When you vaporize something, you're going from something that's, maybe 5 millimeters to 4 millimeters to even the tip of your thing can even be just a few millimeters, but this gap is almost imperceptible. And so that gap, but the energy is still having to flow across that gap, but it's flowing at a high current density. So when you have a huge amount of energy that's flowing through something with a extremely high current density, then you have a huge amount of force that's going through that, and that force just causes the tissues to vaporize. Whereas if you touch the tissue, all of a sudden you've dropped your current density, and that causes the tissue, instead of to completely vaporize, it causes it to dry out and what we call desiccate. So as your electrode side decreases, your power setting requirement increases. So how does this play out in a monopolar circuit? Well, the thing you have to remember is that in a monopolar circuit, so what's happening is you're having electricity, electrons are flowing through the patient this whole time. So why is the tissue destruction, why does it happen at the end of our instrument, of our electrode, and not elsewhere? I just gave you the answer. But if someone wants to give me an answer, so I know you understand.
Because it's not concentrated at the tip.
Because it's concentrated at the tip. Why don't patients get a burn over here? You guys have heard about that happening, right? Pat, those where people get. Why is it here and not here?
It's a wider area, so it's
Yeah.
less voltage.
Exactly. So that's the idea of this. So this is what's happening in our circuit. Is those electrons are still flowing through the patient, but what you're doing is you're going from the energy that's flowing out of your electrode is high current density. So you have high current density here, which is creating a high amount of electrons that are flowing. So that's creating high heat. But those same electrons are passing through the patient. But as it passes through the patient, what's coming out of your electrode, all those electrons, so if you were to measure the temperature here, you probably would get a subtle change in temperature. You just wouldn't notice it because it's not enough to cause tissue damage. Now, one of the safety features that you'll see in the return electrode is that what used to happen was if this pad, so what your electrosurgical generator does is it says, I want the water coming in or the electrons going in, or when the electrons going out to be the same amount going in. I want this circuit to be complete. So I want to sense that things are coming back. But it doesn't know what's happening at the tissue level. And what used to happen was they used to have pads like this. And what happened was if the entire pad peeled off, and if you still had a small amount that was still kind of clinging to the patient, then what would happen is that you would increase your current density in that one area, and then patients would get these pad site burns. So they get these like big burns that would appear on them. And what the safety feature that's in the pads now, in the return electrodes now, is the better term, is that they have these dual sides with this non-conducting strip in the middle. So if you ever look at this, you'll see this. And when you're using this return electrode, both sides here have to be in contact with the patient. The return electrode says, I want energy coming back from both sides. Otherwise, that tells me that you have enough surface area in contact and that you have low current density that's going through here. And so that you're not going to get a site burn. So just is more of a historic thing and safety thing, but that's where this thing comes from. And that's why if you see an error, it's because this thing isn't properly attached, because your generator has a safety mechanism built into it. Now, again, your generator only tells you the energy that's coming back. It's not telling you that's happening in between. So we have these pads that are safe, and they've helped a little bit. But here's an example where you can have your return electrode and have a burn in an area of a high current density. I'm hoping this video works. All right. Okay, do you guys all see that? So here you are, buzzing away, thinking, okay, I'm stopping the bleeding over here, but you don't realize that later on down the circuit, you have something with high current density, and you'll get the energy is still flowing through that. We don't often see it so where this would play out at open surgery, for example, is, let's say if you tied something off, if you tied off a vessel, okay, so now you've tied it off, and now you say, oh, I still want to just buzz the end of it. So I've seen it actually at appendectomy is where you'll do it. So you like want to like buzz that little end of a stump, right? Well, if you buzz the end of a stump, where that energy now is still going back in through the appendix and it's going back out through the patient. But where's your area of highest current density?
Yeah, the tie is.
Where your tie is. And so what happens if you apply amount of energy to where your tie is? Yeah, you're gonna, it's going, I hear all, everyone's making hand motions, but yeah, you're going to, it can break or snap and you can cause damage. So again, I don't know if it's something that's actually been documented as something happening, but it's something to be aware of because it's something that can certainly could happen or cause some sort of injury that you may not actually know, because it's hard to say, because there could be a problem that happens and no one can understand why it happened, and it's not something that you can really look back in retrospect and figure it out, but it is something that definitely has the potential of happening, especially if you're using a lot of energy, and especially if you, so here you can see he's using the coag mode also, right? So the coag mode is generating high voltages, so, and that high voltages are going through the patient, and that's, you're going through that area of high current density. So another place where it can affect you is if you do this. Okay. So we all do this, right? Right? You're stopping the bleeding, you hold the vessel. So there's a few things here that's proper waiting to do this. So when you guys do this, you have a vessel bleeding. How many people have had, someone buzzes and then you get that little jolt because someone just zapped you? Has that happened to anyone? I got one nod. David has nodded. He's been zapped. How many people got zapped?
Once.
Okay. Ali's been zapped.
Yeah.
Anyone else? Okay.
Yeah.
Couple of people have zapped. I've been zapped. So, there we go. So, we've got a few people who've been zapped. So now you zap and then you look and then you're like, oh, I got a hole in my glove.
Yeah.
So you got zapped. Is it because you had a hole in the glove that you got zapped?
No, it's because you don't have enough contact with the instrument. Like if you just had, you're holding it by one finger on the loop rather
Right.
than holding it with more of your hand surface, you're more likely to get hurt.
Exactly. And why? And can you explain it in terms of current density?
It's probably the same thing like your sausage, where it's like
Exactly.
one finger is not as good as having 3 fingers on it.
Exactly. So there's a couple things. So yeah. So that's one thing. So the whole, this person, right? This person's not wearing a glove, right? So this is a giant hole in the glove because it has nothing to do with the hole in the glove, right? The hole in the glove came second. The hole in the glove came second because it was when it came first, the chicken or the egg. So it wasn't the hole that caused you to get zapped. It was the zap that created the hole. That's why you get the hole in the glove. Now, so this is one thing, right? So just remember too, is that if any part of you is touching the patient, well, that's part of the circuit. So if you hold by, so part of that energy is also going through you. You probably don't even realize it if you're doing something like this. So if you're holding with one finger, well, then that's high current density, and again, the energy will go, and if you're holding with one finger and part of you is touching the patient, well, the energy is part of it's going to go here, but part of it's going to go through you, and that's where you're going to get that jolt. Whereas if you have more in contact, well, you have a low current density and less chance of that happening. Now, there are other ways also to make this safer. Does anyone have any thoughts on that?
Not touch above the hand. I don't know, touch it below the.
Right, exactly. So this is bad technique. Again, you want to be close to, energy is going to go where it's going to flow, it's going to flow through where it's least resistance. So if they start up here and it's trying to get through there, well, you create a little bit of a bypass of someplace else where it wants to go. So it's going to go to your hand. Whereas if you start down here, then it's going to be closer to where it wants to go, which is through the patient. So when you're touching the instrument, you want to touch as close to your effective area as possible. Anything else? How about the button that you're pressing? What's the difference between what you press? How might that affect things?
So if you press your cut button, you're doing your like low and slow versus your coag button.
Exactly. So that's the other thing that happens. So if you do the low and slow, then, so which is the preferred mode?
Cut. mode.
Cut, right? So cut has two benefits. So one is it's low voltage. So it's the high voltages, the sudden jump that gives you that zap. So you want low voltage. And also because what are you trying to do when you do this? We're trying to stop something bleeding, right? So if you want, so as I said, right, you want low and slow over time. So it has two benefits. So the cut mode is here. So one is the cut mode helps create a safety by giving you a low voltage, so you're less likely to get zapped, and also provides low energy over time, so you're also more likely to stop that bleeding vessel. Now, again, a lot of people will use the coag button, but this is, so if you don't want to get zapped, tell whoever you're assisting with, say, press the cut button. And they may not fully understand why you're using again, it's a bad term. Why am I using the cut button to coagulate the tissue? Because it's a bad term. You say, because I don't want to get zapped. That's basically it. Now, there's a few other little safety things. Do you see how he's touching the forceps with the side of it? Right? So again, that's an area of high, you can get sparks that happen over there as well, because, and he's touching the side to the side, the edge to the edge. And if there's any separation, well, you're going to create a spark. And a spark will be a high area of, will be a high voltage, and that'll create a zap. So the safety thing to do is to use the flat part of your bovie with the flat part of your forceps. So flat against flat, so you have high surface area. High surface area is low current density. Less likely to create a zap. And I don't know how many things. And the other thing that you want to do is if you activate your electrode, but you haven't touched the forceps yet, and you have it on, and then you touch, what's going to happen as you approach?
Sparking.
It's going to spark. Spark because it builds up what we call capacitance, and then it's going to, because it doesn't have anywhere to go. Now, as soon as it touches, it's going to build up. It's like a hose where you kind of plug it for like a really long period of time. You're plugging the end of the hose. You're plugging the end of the hose, right? You've completely shut it off. And now all of a sudden you just release it. What's going to happen? Well, that water has been built up in the back and it's just going to shoot out. So the safety thing to do is you touch first, then activate. So hopefully if you guys do all these things, no one's going to get zapped anymore. And the other thing to remember though, is this is how also fires start. So, and it's not a thing that hasn't happened before, which is fires in the OR. Now, the other thing to be aware of, also how fires start in the OR, is this idea of capacitive coupling. And this happens because when you have a metal wire, so you have a metal conductor, and you're passing electrical current and you have an insulated field, well, that creates a static charge. And if you bring another electrical instrument to it, then that generates a current. And so so in this example, you have a wire that's in your active and your electrode, and it's surrounded by an insulator. But that's not a perfect insulator. It creates a charge that's around it. If you bring another metal to it, you're going to get a current. And this is an example of where that happens. So if anyone has ever done this, and then you put the snap and you attach it to the patient, don't do this, because this is what happens. You're going to get it here. There you go. Okay, So if that snap is hooked onto your drape and the drape is touching the patient, so what's happening here? Well, you're activating it. So there's a couple other things. You can see that person had his whole hand on his thing because he really didn't want to burn himself. But if you activate your electrode and there's no place for those electrons to discharge, and you have that wire that's wrapped around your snap, and then the snap is attached to the patient, well, if it comes in close contact, if there's a way where this is an area of less resistance than where your electrode is going, then it's going to go there, and then that's going to create an electrical current, and then you're going to have a little burn there, and you're going to have a fire there because it's going to be right over the drapes. So that's why they say don't wrap your instrument in a snap. That's why there's those plastic holders that for the holsters for your electrode. That's why you use that and not the snap. So the whole idea behind this is safety. You're using electrical surgical energy. We're using it for a reason. We're wanting to cause tissue desiccation, tissue vaporization. And the whole idea about safety when you use electrical energy is to use the lowest amount of energy to achieve your desired effect. What your desired effect is, again, depends on, what you're doing. So you'll notice that with different types of surgery, they'll use different types of energy setting. And that really has to do with your current density. So if you're working in a really fine area, sometimes, if people do like vulvar surgery, they really don't want a lot of extra tissue, a lot of thermal spread. So you want a low energy setting because you have a high current density. So if you have a high current density, you want to use a low energy setting because you want that desired effect and you don't want any excess effect. If you're using something with a bit more surface area, then now you have to increase your amount of power to get the same tissue effect. And if you have a ball, well, now you have to go even higher. Now, these were just a few examples, and there's other things to remember that, so again, this is sort of a lot to take in, but the whole idea is that you have all these properties that are going to affect your desired tissue effect. And there's a lot of factors that are into play, and it's up to you to take these into account. So to get any kind of a tissue effect, well, you can change the amount of power. So people say, well, crank it up. Maybe that's not it. You can change the size of your instrument. You can how you use it. So if you use the side of an instrument versus the very tip of it. Patient variables. So if you're going through, if a patient has maybe a lot of atherosclerosis, that tissue may have more resistance. And think about what it is that you're going through. So people know, right, when you have someone who's morbidly obese, high BMI, and you're starting your surgery, you're cutting through your abdominal fat. Well, how easily does that cut through fat? And how do you overcome that? Usually what we end up doing is we end up going through higher power settings because fat has low water content, has high impedance, you're less likely to flow. So in someone who's obese, you might go up to a higher power setting versus someone who's thin. So these are other things just to take in consideration as you're going through. And same thing, depending on where you're trying to stop that bleeding vessel, because when you try to pick up a bleeding vessel, you don't pick up the bleeding vessel, you pick up everything around it. So if you're trying to stop that bleeder within the fat, big amount of fat, well, that fat is not going to conduct very well. So you may need to either spend more time to allow it to completely penetrate all the way through, or you may need to go to a higher power setting versus if you're stopping a bleeder, let's say if it's on the muscle, that may have more ability to conduct. Now, that was a lot. This is all you need to remember. Vaporization, vulgarization, desiccation. Keep those in mind, okay? So, tissue effect is a function of heat over time. Keep that in mind. Heat energy over time. Cut mode versus coag mode. High energy over a short amount of time or low energy over a longer mode of time. The amount of energy that you deliver over a period of time will have a desired effect on your tissue. So whether it's a whole bunch of char or it's your turkey that's cooked all the way through. And be aware of these concepts of current density because they may play a role in achieving your tissue effect and potential for injury. And also for capacitive coupling as another area where you may have a potential injury. That's it.
I just want to say thank you. A lot of things have suddenly made sense, started making sense now.
It makes sense, right? And when you think back to all those times you're in the operating room and something worked or didn't work.
Yeah.
And nice to have it. It's funny, as you say, you just have to keep looking at it because you forget. So Tom's recorded this, and one of the things we'll let you guys know is it will get posted on a website that we could forward the link to so that you can look at it again.
Excellent. That's just what I was going to request, if we can, share the slides, but that's great if you have a recording.
Can you talk a little bit, Neeraj, about like the blend function?
Yeah, so the blend function it's basically a middle mode. So I'll go back to here. So all the blend, so there's all these blend buttons, and all it is it's your duty cycle. So it's in between your cut and your coag. So depending on what the setting is of the generator, a blend mode just affects your duty cycle. So all it is it's a desired tissue effect. So I like to be a purist because when I'm doing that, I like to think about do I want a purely modulated or unmodulated current? A blend mode basically gives you some sort of tissue effect that's somewhere in between. What I'm saying is none of these things, there's no right or wrong in terms of what you use in terms of an energy setting. There's basically ones that give certain effects, and some ones are probably, and each one has effect that's probably more desired and one that's less desired. Again, all of these modes, at some respect, depending on what you're trying to do, will achieve the same effect. If your effect is to try and stop bleeding, well, any one of these modes is going to achieve the same effect depending on how you use it. And so, some people use a blend mode because they say, well, if I use a pure cut, I still get bleeding and I don't want that bleeding to happen. But if I use this, then it sticks because that's what it does, right? It creates char, it desiccates the tissue, and it doesn't allow you to, it doesn't vaporize. So this kind of gives some effect that's in between. It's a bit of that desiccation with a bit of vaporization. That's basically all it is. So if it's helpful, you can use it. I really find no utility for using any sort of blend mode. I think it just confuses the issue, to be honest.
I also have a question about power, I think. Yep. So when you personally set your settings for your electrical surgical unit in your OR,
yeah.
If you were doing what we do,
yeah.
which would for most people be cesarean sections,
yeah.
I honestly feel like the staff didn't necessarily remember or know all of this when they were teaching me this. So it was kind of haphazard who picked what numbers for what reason. So yeah. I just wonder if you could give us an insight into what you do.
So for most, let's say open surgery, cesarean section, the energy settings that I use the lowest power energy setting to achieve my desired effect. And for most patients, that's usually around 30-30 for the tissue effect. because I get what I want to do with the least amount of char, and because char and accessory tissue damage. That's kind of how I look at it. But again, it depends on the patient. So again, if I have a patient with a high BMI, I'll probably go higher. I might go 40. I might go 45 if there's really a lot of adipose tissue. Sometimes even you have adipose tissue. Sometimes you get the adipose tissue that's a little bit juicy, and then you get some where there's like no conduction at all. So it really just depends. So I may go up on the power setting depending on the patient. I probably wouldn't go any more than, I don't think I've ever gone more than 50 on an open surgery, but there, or I may start off higher, like getting through the initial fat, and then I may drop down my energy setting once I've gotten past that area. Once I'm down to fascia and muscle, then just lower it. Just say, hey, can you lower the energy setting down to 35 now? Because you don't need that much. Does that answer the question?
Quick question
Yeah,
here.
that's a much better answer than that's just the way we do it. So thank you.
That's the whole thing I'm trying to get away from. So that's what I said. So, and you'll find that I say that about a surgery and law in general is everything you do, it's good to ask why you do it and understand why it is. And a lot of the rationales are historical, and a lot of times there is actually good rationale for people doing what they do. And then ultimately it's just making the choice that fits for you. But yeah, as long as you have a reason that's besides of that's the way we do it. Or that's the way I've always done it, because it may not be the right way of doing it.
Neeraj, you gave the example of cauterizing the appendiceal stump. If you're doing a salvagectomy and you tie off the proximal end of the fallopian tube, do you cauterize that tip? And if so, do you do it before or after you tie, or is that being silly?
You're saying at a salpingectomy?
Yeah.
Yeah. Again, it's the same thing. So I will fulgurate the end if it's bleeding, right? So, well, what does fulguration do? Well, fulguration provides, I recognize that it's something that can happen, but it fulgurates just a small amount of char just on the top with a little bit of penetration later on down below. So I'm just creating that little bit of char superficially to stop the bleeding. I'm not grabbing the end of it and cooking it or desiccating it in that sense. So if I did like the old like a Pomeroy tubal or something like that, then yeah, I'd get the ends of it by fulgurating, because I still tied the rest of it. But and also you've mostly achieved your tissue effect anyways by the fact that you've cut it and snipped it. I'm not worried too much about bleeding at that point.
I guess my question around that, I had a similar question, was that one attending that I was working with, they used monocryl to tie off for their salpingectomies. And so if you're using that sausage analogy, though, I'd be concerned if they've already tied that most narrow part is being held by a meltable suture. And so I'm wondering, would that actually increase the risk of that suture failing?
Yeah, I mean, it's a possibility. It's not something I've ever actually, I haven't seen it like tested out to say, like, it might be something I'd be curious to do that actually in a lab, like in a pig lab or something, just next time, just to experiment, like how long, or if it would actually happen. But like theoretically, yes, like there is that risk of definitely that suture failing. Especially depending on how much energy you apply to it and over what period of time. So it's because you just have to think about where's that circuit going. So if you've tied it off, you've created that choke point, and you're coagulating on one side of that tube, and the only way back to your return electrode is through that narrow point where you've tied it off. Well, now you've created an area of high current density. And if you're using a thin suture that's prone to break, well, yeah, it could happen.
Yeah, it's ironic because I don't think that they were using the cautery for hemostasis. They were using it as an insurance policy just to make sure the tips were not going to reanastomose. And instead, they could potentially be opening up the tube. So anyway, so that's helpful for me to think about. Not that I use monocryl for that, but
yeah, it's something to think about, something to be aware of. I think a short little burst, I'm not concerned about that. Like, I think it's fine. It's just if you were to apply it over a longer period of time, then it's just definitely something to be aware of for sure.
I have another technique question.
Yeah.
Again, this is just what I was taught, so that's why I want to ask, is that if you were looking for more of a vaporization action, like you were trying to cut tissue, then I was taught that you were basically supposed to hover almost above the tissue for that to happen, and then fulgurating you want to be touching. Is that right?
No. So fulguration, desiccation, and vaporization. So vaporization is with cut mode only, right? So you just touch the tissue and it vaporizes. Fulguration is with coagulation mode. Okay, so coagulation. So both vaporization and fulguration are two ends of the same. So the technique is the same in terms of the distance. You just hover but don't touch. Okay, but if you activate the cut, you'll get that constant energy over time that will vaporize the tissue. If you hit the coag button, you'll fulgurate because you'll get a huge burst of energy, which will create char on the top, and then it won't, because of the 6% duty cycle, it'll just dry out the tissue, but it'll create char, and then it'll create resistance of flow, so it won't be able to vaporize because now you've already burnt it to a crisp. If you were to touch the tissue, then you're doing what's called desiccation. Okay, so desiccation is when you touch it now, because you've decreased the density enough that desiccation dries out the tissue. Now, depending on what button you activate or what power setting you use, there's two ways to achieve the same tissue effect. But if you use coag or cut, you'll dry out the tissue. Now, what happens to that tissue will depend on how much power you're using or basically the amount of energy that's going through the tip. So what type of tissue it is, how much power setting you're using, what type of tissue, and what mode you're using. So if you're using a cut mode with a lower power setting, then you'll slowly dry out that tissue just like you're cooking the turkey, okay? If you're using a high power setting and you're using a coag mode, then you're gonna cause lots of energy over a short amount of time, and then you're gonna burn that area to a crisp, lots of tissue destruction around it, but you may not actually, depending on what you're trying to achieve, if you're trying to stop a bleeding vessel, well, you still may not have gotten down to the center of the vessel and actually denatured the collagen within the vessel itself.
Thank you.
Any other questions? You guys all got the handout or that reading? Okay. Hopefully now it makes, if you haven't read it before, hopefully reading it now makes a little bit more sense. It's kind of a heavy read otherwise, but it's not an easy topic to understand. Like I said, a lot of people don't fully do it. I probably don't do it justice because I'm not a physicist, so, or an electrician either. So there's probably concepts of it that are still beyond me, but it's interesting to know nonetheless.
That's awesome. Thanks very much, Neeraj, and thanks you guys for your questions. That's actually really helpful.
Thank you.
So feedback, is this format works, everybody?
Yeah.
Okay.
I actually find I concentrate much better, without any distraction, but.
Nice.